Hi guys, so welcome back to Vlog Media. It's me again, Mark, and during the last video we were able to talk about the part 1 of ECG, so we're going to talk about part 2 of ECG. But if you haven't watched about the ECG about the previous one, so you can click this link above here just to watch the first part, and we'll now continue on the second part. So let's see you there, guys. Heart rate. So in the previous video we talked about the normal ECG tracing and how to determine the axis. So for this video we will talk about some abnormalities in heart rates. So basically the normal heart rate is about 60 to 100 beats per minute in the resting heart rate, and anything that's less than 60 is bradycardia, and anything that's more than 100 is tachycardia, which is a fast heart rate. So let's go to supraventricular tachycardia. Well, these are actually fast heart rates of regular rhythm that typically arises from the bundle of His. It's either in the AV node or SA node. So typically you can see that they're quite fast, and the R to R interval are quite narrower, are quite near to one another. So they're about 100 milliseconds or less, and you can see that they're regular. In this ECG tracing, you can't really see the P wave because the P wave is really buried under this area here. So you can't really see the P wave, but they're actually indeed P waves here. They're just buried in the QRST complexes. Okay, so let's now move to another abnormality, which is a premature ventricular complex. These are what we call skip beats, and these are bizarrely wide QRS complexes of about more than 120 milliseconds. And they're not usually preceded by a P wave. So as you can see in this tracing here, we have a normal beat here, okay, which is composed of the P, QR, S, and T, and another normal beat here, followed by an abnormal beat, which is about, the QRS complexes is about more than 3 small squares or more than 120 milliseconds, and they look really bizarre. So they don't really quite look normal as these previous 2 beats, but they're rather abnormal in shape and size. So this is the premature ventricular complex. So let's now go to what we call a ventricular tachycardia. So ventricular tachycardia is defined as more than 3 successive premature ventricular beats of a rate about 100 to 150 beats per minute, and it can be either sustained if it lasts for about 30 seconds, but if it lasts less than 30 seconds, it's called non-sustained. So ventricular tachycardias can be monomorphic or polymorphic in appearance. So this is the monomorphic ventricular tachycardia. As you can see here, these are all bizarre QRS complexes of about more than 120 milliseconds, and we don't see any P wave. So as you can see here, they are QRS complex is very wide. So as compared to the SVT, supraventricular tachycardias, they do have very wide QRS complexes, and they don't have a P wave. Well, similarly to SVT, they don't have P wave as well, but as you can see here, they look really bizarre, and the QRS complexes is really wide. So next is the polymorphic ventricular tachycardia, or torsade. So these are really bizarre looking QRS complexes, but you can see that they vary in size and amplitude, and they seem to twist around the points here. So we call this torsade one as well. Okay, so another abnormality is called ventricular fibrillation. It's an ECG where there is no QRS waves, just fibrillatory waves about 155 rate per minute. Okay, so every time we talk about irregular heart rhythms, so we should ask ourselves the question, is there a P wave? So if there are P waves, usually the conduction comes from the SA node or an atrial pacemaker, but again, not all of the time, because as we mentioned earlier, in supraventricular tachycardias, we don't really see the P waves. Now, if there's absent P wave and the rate is really irregular, we call that atrial fibrillation. So this is atrial fibrillation. So in atrial fibrillation, there is no discernible P waves. We don't see any P waves, and the rate is irregular. So as you can see in the strip here, okay, there is we can't really see P waves, and the rate is really irregular. The R to R interval here is a bit shorter compared to the other one. So there's no regularity in these heart waves. In this, yep. So next we go to atrial flutter. So in atrial flutter, you can see sawtooth P waves, such as you see here. You can see the P waves. It looks like a sawtooth, and an atrial rate of about 250 to 350 beats per minute. So in this particular tracing here, you can see that there are, in this area here, you can see 3 P waves before it conducts, and here you can see 1, 2, 3, 4 P waves before it conducts. So this is well, 3 or 4:1 P waves is to 1 QRS. But if you can see this typical pattern here, you can see that it's really a sawtooth. It looks like it really resembles like a sawtooth, and it is an atrial flutter. So another irregular heart rhythm is what we call a wandering pacemaker. So typically when you talk about heart rate, so usually the initial conduction comes from the P waves, which is generated in the SA node. As you can see here, this is where it originates. So the P wave originates from here. However, in wandering pacemakers, the P waves generated from other areas of the heart, such as in this area here, or in this area here, or elsewhere. So it has different areas of where P waves begin, so not only in the SA node. So therefore the PR interval here may differ, because if the pacemaker is being generated in this area, the P wave may, well, the PR interval may differ, and so forth. Okay, so the heart rate is really normal in wandering pacemaker, but the amplitude of the QRS may differ from each beat depending on where the conduction is coming from. Okay, so we call this abnormal generation of P waves the ectopic focus. So in a wandering pacemaker, you can see that the heart rate in this, I think this is a 6-second strip. You can see that the heart rate is about 100, but you can see here is about irregular. But the only thing is that you can see P waves. Okay, so you can see P waves. So these P waves here, they don't really look the same though. If you can just simply try to examine them, they look different from one another because they come from different areas of the heart. That they still generate the P waves, but they're just being generated at different places, not at a fixed place. Also, you may notice that the amplitude of QRS are different. So this is an example of a wandering pacemaker. In contrary, in multifocal atrial tachycardia, it is quite similar to wandering pacemaker, except that the heart rate is faster at more than 100 beats per minute. There are P waves, but the P waves look differently. Okay, you usually see them in patients who are chronic smokers. Alright, so let's now talk about heart blocks. So normally the conduction comes from the SI node going to the AV node and into the bundle of his, goes into the left and right bundle, and lastly to the Purkinje fibers. So we have AV heart blocks such as the first degree heart block, the second degree heart block, and the third degree heart block. Okay, so also we'll talk about bundle branch blocks, which is the right and the left bundle branch blocks. So first let's talk about the first degree heart block. So this includes about prolongation of the PR interval of 0.2 seconds or more than 200 milliseconds, which is about 5 or more small squares. So as you can see here, you can see that the PR interval is quite prolonged. As we mentioned in the first video, the normal PR interval is about, well, less than 0.2 seconds, so 0.16 to 0.2 seconds. But in this ECG tracing, we can see that the PR interval is more than 5 small squares, and this is a first degree heart block. Okay, let's now move to a second degree heart block, which is about two types. We have the type 1, or Mobitz type 1, or type 2, which is the Mobitz type 2. So the second degree type 1 block, which is called the wank back. What's really unique about this heart block is just that for every beat there is a increasing interval of the PR, okay, until it drops a beat. So what really happens is that you begin with a slightly prolonged PR interval, and the next beat will have a slightly longer PR interval, and the other beat will have a longer one until it drops a beat, and the cycle goes back again. So the shortest PR interval occurs just after the drop beat, and the longest PR interval occurs just before the drop beat. So what do I mean by this? So let's take a look at here. So you can see here that the PR interval is getting more prolonged. So it's already prolonged here, but it just seems to prolong and prolong and prolong. So I tried to measure the PR interval. On this beat is about 240 milliseconds, and the next is 320 milliseconds, and the fourth beat is 360 milliseconds. You can see that the PR interval here is getting more prolonged until such time that it will just simply drop a beat. It will not conduct. So this is what we call the drop beat, which is no QRS, and the cycle will begin again. So yeah, so that's the Mobitz type 1, or second degree type 1 heart block. Okay, so let's now go to second degree type 2 heart block, which is the Mobitz type 2. So what's really weird here is just that the PR interval is in conducted beats remain constant. Okay, the PR interval can be slightly prolonged or normal, but the P waves just simply marches through at a constant rate. So it doesn't really, the PR interval does not get prolonged with every successive beat. It just tends to drop. So the R interval of the beat drop is the multiple of the normal R intervals, and can progress to a complete heart block or third degree heart block. So what I mean is that you can see that there are constant PR intervals on these conducted beats, but you can see that it will just simply drop a beat. Okay, so the next P wave will either conduct or not conduct. So that's the second degree type 2 block. Now this is a lot more dangerous situations compared to Mobitz type 1, because in Mobitz type 2 you can see that there are constant P waves that are, well, conducted through a QRS, but you can see here that there's a drop beat, and you can never be sure that there will be a QRS interval in the next P wave. So if that occurs, then the second degree heart block can progress to what we call a third degree heart block. So by the way, second degree type 2 heart block is caused by a damaged part of the conducting system, which is on the AV node or the bundle of His. So there's an intrinsic damage in this area here. That's why it conducts, but sometimes it does not conduct. But the feared thing here is that what if this one really gets permanently damaged and does not conduct anymore? Okay, so yeah. So let's now talk about third degree heart blocks. If the AV node or the bundle of His is completely cut off from the rest of the heart, then a third degree heart block will occur. So this is known as the, well, of course, complete heart block, and the SA node does not conduct through the ventricles, so the QRS and the P waves are independent of one another. So what you can see here, now the thing is that when you disconnect the SA node from the AV node or bundle of His, you just cut that connection, what will happen is just the P wave, the SA node will continue to generate the impulse, which is not really conducting. So what will happen is just the ventricles will actually automatically try to beat on its own at a rate of about less than 40 beats per minute. Well, that kind of heartbeat is not sufficient enough to pump blood well, to the brains. So what really happens is that for this kind of scenarios, patients do lose consciousness, they do have chest pains and all those things, and this third-degree heart block needs a pacemaker, which is it really needs a pacemaker for it to beat well. So in this particular scenario, usually a pacemaker, well, an artificial pacemaker is needed, because the natural pacemaker, which is the SA node, is simply disconnected. So if it's disconnected, then we need a artificial pacemaker to be inserted so that it can conduct the beat through the ventricles at a desirable rate. Because in third-degree AV block, the ventricles will just simply beat on its own, which is what a phenomenon called a ventricular escape phenomenon, but it's not enough. The rate is not enough to sustain adequate blood flow to the brains or to the other parts of the body, because it will just beat at the maximum rate of about 16 to 40. So as you can see here in this ECG slide here, you can see that yes, there are P waves, but the P waves not really related to the QRS complex anyways. And you can see that the QRS complex are really far apart from each other, and patients are really bradycardic in this kind of scenario. Therefore, a artificial pacemaker is required in this scenario. Yep. Okay, so let's now move to bundle branch blocks. So you have the left bundle and the right bundle, and let's first talk about the right bundle branch blocks. So as you can see here, this is the area of right bundle branch. So usually in right bundle branch blocks, the defect is in the right bundle branch somewhere here. So right bundle branch blocks is right. Okay, the bundle here actually does not really conduct it doesn't really conduct electrical impulses from the SA node that well as compared to the left. So there are ECG changes that can show this branch blocks. So the right bundle branch, so to say, actually is responsible for the beating of the right side of the heart. So if this is actually a defect, then you can see that it will manifest in the delay in the QRS complex. So there's a criteria for the right bundle branch block. So the criteria are as follows. So the QRS duration is greater or equal to 120 milliseconds or 3 small squares. In leads V1 and V2, there is a R, S, and another R, which we call an R prime. In leads V1, 2, in leads V1 and V6, you can see that the S wave is of greater duration than the R wave, or the S wave is greater than 40 milliseconds. And in leads 5 to V6, in leads V5 and V6, there is normal R wave peak time, and in lead V1, the R wave peak time is greater than 50 milliseconds. Okay, so in this scenario, you can check the QRS complexes. Okay, the QRS complexes tends to be more than 120 milliseconds, therefore, and it's followed by a P wave. So this is not a ventricular premature complexes, because it's followed by there's P wave followed by QRS, except that the QRS is more than 120 milliseconds. So how do we know whether this is a right or a left bundle branch? Well, you can see an R, you can see an S wave, and a R prime. So this is the initial R, and you can see the S wave and a big R prime. You can see that when you take a look at the V1 here, okay, normally the right bundle and the left bundle, they usually tend to conduct at the same time. But if you have a delay in the right bundle branch block, you can see that this is the left bundle being conducted, but there's a delay in your right bundle. So you can see that the V1 is actually, when you put an ECG on V1, it really focuses on the right side of the heart. So you can see here that the right ventricle beats is delayed as compared to the left. So you can see an R, small r, an S, and a big R prime. Okay, so that's one side, and you can see here, and there is actually in V6 you can see that there is a delay in your S wave. So you can see an R and an S and a delay in the S wave here. Okay. So the S wave is greater in duration than the R wave. Okay, let's now go to the left bundle branch block. So the criteria for that is the rhythm must be of supraventricular origin. Okay, and the QRS duration is again greater than 120 milliseconds. However, in V1 though, you can have either a QS or a small R wave with a large S wave. And inversely, in V6, you have a notch R wave and no Q waves. So let's take a look. So as you can see here, in lead V1, okay, so initially the QRS is more than 120 milliseconds, but you can see in V1 that there's a deep S wave, and you can see that in V5, in V6, that you can see a notched R wave. Well, sometimes there's really no Q wave, so your Q here is simply a QRS of 120 milliseconds, a deep S wave on V1, and a notched R wave on V5 to V6. Okay, similarly, you can see here, okay, a very small R wave but a deep S wave, okay, on V1, and a prolonged QRS complex. Okay. You may not see some notching, but this clearly shows that this is a left bundle branch block. So let's now go to chamber enlargement and hypertrophy. So we can also detect enlargement of the atrium and thickening of the left or right ventricles through ECGs. So we have a voltage criteria called the Sokolov-Lyon criteria, wherein the S wave in V1, if you add them, okay, the number of small squares in height of the S wave V1, you add it with the tallest R wave in the V5 or V6. If it's more than 35 small squares, then you can say that the ECG tracing has a left ventricular hypertrophy. Also, you can also detect left ventricular hypertrophy by adding the R wave in lead 1 with the S wave in lead 3. If it's more than 25 millimeters or 25 small squares, then you have left ventricular hypertrophy. Alternatively, if you have a large R wave in the AVL of more than 11 millimeters, that's left ventricular hypertrophy, or what we call LVH. Big R wave at the AVF at more than 20, or a deep S wave on AVR of more than 14. So you can consider calling it a left ventricular hypertrophy. There's also non-voltage criteria to determine left ventricular hypertrophy. This is what we call the SC segment depression or T-wave inversion on the left side leads, also known as left ventricular strength pattern. but you need to have that voltage pattern, and you have this non-voltage pattern to make the criteria. Okay, so you have the V1 here. You have the S wave. So you can add the S wave here. Okay, plus the R wave in V6. So you have in V1 lead, you have the S wave of about 19 millimeters. You add that to the R wave, which is about 23 millimeters, or 23 small squares. So you got a total of 42 millimeters or 42 small squares. So also you have that SC segment depression. Okay, so these are ventricular repolarization changes or T-wave inversion in V6. So that's diagnostic of left ventricular hypertrophy. As mentioned, so another criteria is an R wave and AVL of more than 11 millimeters. But this side here is the Sokolov-Lyon criteria. Okay, so let's go to right ventricular enlargement. So for the criteria, you have a right axis deviation of 110 or more. You need to have a dominant R wave in V1 and a dominant S wave in V5 to 6. So a dominant R wave in V1 should have more than 7 millimeters tall, or a RS ratio of more than 1, and a dominant S wave in V1 to V6, which is about more than 7 millimeters deep. And the QRS duration is less than 120 milliseconds. So other supporting criteria includes deep S wave in lateral leads, 1 AVL, and the V5 V6, and right ventricular strain with SC depression and T-wave inversion in V1 to 4. Okay, so criteria for right ventricular enlargement in this particular slide is in V1, you can see that the R wave is more than 7 millimeters. Now in this area here, you have right axis deviation, and we can see a dominant S wave in V5 to V6, which is more than 7 millimeters or 7 small squares, and you can see a right ventricular strain in these areas here. Okay, so let's now move to right atrial enlargement. So the criteria here is just to look for the P wave. Okay, so if the P wave is more than 2.5 millimeters high, if it's a tall P wave, it's about more than 2.5 small squares in lead 2-3 AVF, you can diagnose it as right atrial enlargement. And if it's more than 1.5 millimeters high in V1, V2, and that's right atrial enlargement. So you can see here in leads 2 that the P wave is 2 millimeters high. Okay, similarly in leads 3 and lead AVF. Okay, so that's right atrial enlargement if it's a tall P wave, especially on 2-3 AVF, more than 2 millimeters high. Now conversely, in left atrial enlargement, you would want to look for the length of the P wave. Okay, so if the P wave is more than more than 2.5 small squares, or three small squares in lead 2, then you have a left atrial enlargement. Okay, in V1 you can see a biphasic P wave with terminal negative portion at 40 millimeters duration, and a biphasic P wave with a terminal negative portion of more than 1 millimeter deep. Okay, that's left atrial enlargement. So basically, in left atrial enlargement, just try to look for the length. So if it is more than 2 small squares or more than 3 small squares, okay, especially in lead 2, that is left atrial enlargement. Okay, so that ends the ECG lecture for today, and these are my references. And of course, thank you very much for listening, and let's see you in the next video. Okay, bye for now. So if you like this video, please like, comment, share, and subscribe.